This is Edward Daniel. Welcome to Me, Med, and More. Tracheostomy refers to a creation of a communication between the trachea and the overlying skin. Tracheotomy versus tracheostomy. Tracheotomy is the formation of an opening that will close spontaneously once the tracheotomy tube has been decannulated, while tracheostomy is a formation of a permanent opening that remains open after the removal of the tube. Indications for tracheostomy include patients with upper airway obstruction, respiratory support, pulmonary hygiene, elimination of dead space, treatment of obstructive sleep apnea, and prolonged mechanical ventilation, especially those with respiratory disease, neuromuscular disease, and depressed mental status. For the relevant anatomy, important landmarks include the laryngeal prominence, the jugular notch, the cricothyroid membrane, and the cricoid cartilage. Instruments used: local anesthetic, suture set, tracheostomy tube, suction, surgical set with a scalpel and forceps, electrocautery, retractors. First, place the patient in a supine position with the neck extended by a pillow or bag placed under the shoulders to deliver the trachea out of the thorax and to give access to the cervical trachea. Then, palpate and identify the cervical landmarks, starting with the thyroid cartilage, cricoid cartilage, and suprasternal notch. Then, 2 finger breadths from the sternal notch, mark a line for incision. Then sterilize the skin of the anterior neck and chest, and then drape the patient properly. For the infiltration of the anesthetic, unless the patient can safely be intubated or ventilated with a mask, the ventilation should be done with local anesthesia. The skin, soft tissue, and trachea should be infiltrated with local anesthesia with adrenaline before induction. Next, make a horizontal incision along the marked area through the dermis, and the subcutaneous tissue is then dissected using an electrocautery. Intermittently palpating for the airway at this point is important as it's easy to stray away from the midline. Once the fascia has been cleared away, identify the strap muscles and retract them laterally. Then expose the trachea by carefully parting the exposed tissue with a pair of scissors. Tracheotomy is done between the second and third tracheal rings and extended to an appropriate distance. Then create a Jork flap for tracheostomy tube changes. Reflect the flap inferiorly and suture it to the skin. Then insert the tracheostomy tube into the tracheostomy, making sure it does not produce injury and fits the lumen perfectly. Then secure the flanges of the tracheostomy tube and pass them around the neck. Tie them with the neck flexed. Complications of the tracheostomy can be classified as intraprocedural, early, just less than 7 days, and late, more than 7 days. Intraprocedural complications include airway fire, where despite being a rare complication, is commonly found in tracheostomy. The drapes, ETT, alcohol-based antiseptics are all potential fuel sources. Next is bleeding, where it is usually secondary to anterior jugular vein injury, or the bleeding edge of the thyroid. Lastly is pneumothorax or pneumomediastinum, which may be due to the direct injury to the pleura, dissection of air along the trachea, or rupture of an alveolar bleb. For the early complications, these include infection, tube obstruction, and accidental decannulation. For the late complications, these include tracheal stenosis, tracheoinnominate fistula, tracheoesophageal fistula, and tracheocutaneous fistula. I hope to see you in my other videos on me, med, and more.